What's up, y'all? It's the PA Professor back with another video. Today we will be going over dilated cardiomyopathy. So let's go ahead and get started. If you know nothing about the disease, just read and interpret. Dilated, which means dilated or enlarged, cardiomyopathy, cardio heart, myopathy, disease of the muscle. So this has something to do with a disease of the muscle of the heart being dilated. So let's get started. The definition I have for you guys, this is my definition. This is just a condition when the ventricles or ventricle are dilated and weak. So what happens if our ventricles can't pump? Well, we have a systolic dysfunction. Systolic means contraction, right? So you have a problem with the contraction of your heart and you can't pump out the necessary blood you need to your body. Therefore, this blood starts to back up in other places. We'll get to that a little bit later. One of the more high yield things about this topic, overall in general, it's not very high yield, but one question I did receive on one of my EORs was, what was the most common type of cardiomyopathy? And I actually got this right. It is dilated cardiomyopathy. 90% of all cardiomyopathies will be dilated cardiomyopathy. And, dilated cardiomyopathy is not going to come up very often on all your exams and stuff like that. But I did receive a question regarding what was the most common type. So I would know that. Keep that in the back of your head. One of the more high yield things about dilated cardiomyopathy is actually the etiology, the cause. So for the most part, it's idiopathic. It just happens. However, in a vignette, they're going to have to give you a reason, right? They can't just say, this person came in with shortness of breath. What is it? So a lot of times you will see that dilated cardiomyopathy is actually caused by a viral infection, and it'll actually show up in a vignette like a 30-year-old woman comes in with a 5-day history of low-grade fever, cough, congestion, right? And then a few days later, here comes the shortness of breath and fatigue and whatnot. But I would remember this. This is pretty high yield. The patient is going to have a history of a viral infection. Some other things that I've seen about this on exam questions and stuff like that is actually a chemotherapy agent called doxorubicin. It can be cardiotoxic to some levels. So if you see this, the patient was, on chemotherapy, now they're developing shortness of breath, and you look at the imaging and it shows the correct findings, this could be the cause of it. Also, alcohol can cause this kind of stuff, but this is very low yield. I would just know viral infections, honestly. Your symptoms, well, we know we have a systolic dysfunction, so if we can't pump, the blood's going to back up, right? So if it backs up to our lungs, right, we can have dyspnea on exertion, we can have shortness of breath, and we can have cough, right? And then we can also have pulmonary edema. If the right ventricle is dilated, it's going to back up to the rest of the body, right? So if left-sided is dilated, it's going to back up to the lungs. If the right side is dilated, it's going to back up to the rest of the body. So you need to know how to interpret these findings or these signs and symptoms on which ventricle is dilated, because based on these symptoms, you can actually tell which ventricle is dilated. So if this person comes in with cough and congestion, right? Coughing, chest congestion, it's probably the left side that's dilated. If they come in with peripheral edema, swelling in their ankles and legs, it's probably the right side that's dilated. Another high yield thing you need to know, and I should have bolded this, but viral prodrome is common. So like I said, in a vignette, it's gonna be a 30, 40-year-old healthy person, and they're gonna come in with shortness of breath or dyspnea on exertion, and they're going to give a 5-day or they're going to say 5 days prior to coming in they had this low-grade fever, cough, congestion, sore throat, whatever your typical viral prodrome symptoms are, and then they're going to develop these other symptoms, these heart failure symptoms, a week, 2 weeks post-viral. So that is very important. The viral prodrome is very common, especially in vignettes. Your signs and PE findings, your physical exam findings, you will often see a third heart sound, and usually this third heart sound is seen in heart failure, and it's due to a volume overload of the chamber. So if you have all this blood backing up, it collects into that atria, and then boom, all at once the valves open, and you got this overloaded amount of blood going into the ventricles, and it kind of makes a third heart sound, and that is what this is. Also, you can hear crackles if you're auscultating the lungs, right? You can also see JVD if you turn this patient's neck, and then you can also have peripheral edema. Usually your more high yield things will be this edema. Okay, so you have this patient and you want to do an imaging test of choice. What is your test of choice? You're probably going to do this chest x-ray initially, right? But your test of choice would be this echo, because this echo is going to show us if that dilated ventricle, well, first, if the ventricle's dilated, but then it's also going to tell us how well it's pumping. So your normal ejection fraction, you guys should know this, is between 50 and 70%, right? So if you perform this echo and you see their ejection fraction is 40%, something's going on. Initially, if you order this chest x-ray, you're going to see you might not see anything at all, but you might see cardiomegaly. This is another sign of heart failure. What do you consider cardiomegaly? You guys should know this as well. If the heart silhouette covers 50% of the thorax's width on the chest x-ray, then that's usually considered cardiomegaly. Your treatment, what are you going to do for this patient? So let's just first off go to this second point. If this patient presents in the ER and they're volume overloaded and they're hypoxic and they can't breathe, can't catch their breath, probably want to diurese them. If they have edema, right? If they have edema or congestion and you hear it, you probably want to diurese them. Now, this is kind of debated on this heart failure treatment. Should you put them on an ACE inhibitor, beta blocker, mineralocorticoid receptor antagonist, I think that's what that is, and an SGLT2 inhibitor? You can, right? Especially if it's chronic. But a lot of times this is kind of like a self-limiting disease. So usually high yield, I would focus on this diuretic. I think I had a question about that in Roche, but I don't think I've ever had a treatment question for dilated cardiomyopathy in the PANCE or EORE. You just need to be able to identify it, but have these in the back of your mind. Your typical big four drugs that decrease mortality and heart failure are your ACE inhibitors, your beta blockers, your MRA or spironolactone, and your SGLT2 inhibitors. You need to know these for heart failure, not so much for dilated cardiomyopathy. And then, like I said, if they're volume overloaded, probably want to diurese them. Caution with beta blockers. Say you do decide to put them on a beta blocker. Well, are they in acute heart failure? Are they hypoxic? Are they congested? Do they have edema? You need to be careful with these beta blockers because what's their mode of action, right? They're not only a negative chronotrope, which means you slow the heart rate down, but they're also considered a negative ionotrope, which means they decrease the force of contraction by the ventricles. So, especially in acute heart failure, I would be careful with these beta blockers. But in chronic long-term heart failure treatment, these can be good because they kind of preserve that ability of the ventricles to contract. NSAIDs, what if they have chest pain with this? What is this mode of action? So they decrease and block prostaglandins, right? But they also cause sodium retention. What does sodium retention do? Increases water retention. Do we want to increase sodium and water retention in someone who has acute symptoms of volume overload? Probably not. So I would not give them an NSAID, and I would be careful with beta blockers. If anything, I think what you're going to see on your answer choices is this diuretic. So with all that being said, let's do a high yield vignette question, and this is 95% of what the question on dilated cardiomyopathy is going to be right here. A 47-year-old female presents to the clinic for a 2-day history of increasing shortness of breath. She states that she had a low-grade fever and a headache 5 days prior. Her medical history is not significant and she is considered healthy. On physical exam, you notice crackles and peripheral edema. A chest x-ray shows cardiomegaly and increased pulmonary vasculature, signs of overload. Vitals, temperature is 98, heart rate 99, respirations are 21, little tachypnic. BP is 130 over 80, and O2 is 92%. So she is borderline hypoxic. What imaging modality should you order to confirm your diagnosis, and what medication should be initially started? So for the first question, what imaging modality should you order? You want to see if this heart, well, you should be thinking dilated cardiomyopathy just by the vignette. But what imaging modality should you order? You should be thinking an echo. You want to see, right? You want to see what your ejection fraction is, okay? So you want to order that echo. That is the imaging modality of choice. What medication should be initially started? Well, what are her symptoms? She has crackles and she has peripheral edema. She has chest congestion, right? She also is borderline hypoxic, probably because of the fluid retention, right? Or not the fluid retention, but the backup of fluid in her lungs. So she probably needs to be diuresed with something like Lasix. What would you see on imaging? So say you got the first question right? The echo. What would you see? Well, you could see a decreased ejection fraction, but you should see, and if a question asks this, you should see a dilated ventricle. And that is how you know that you have dilated cardiomyopathy. Those are all your high yield things that you need to know for dilated cardiomyopathy. If you like this video, give it a like and a subscribe, and we will be doing more of these in the near future. You guys, good luck on your PANCE, EOREs, EOCs. You're going to do great. Thank you for watching, and we'll see you on the next one.